We could spend a semester talking about the history of what happened in the 19th century, but we're not. We did spend quite a bit of time talking about Broca. I just want to mention, simply because we need to, Wernicke, which is the other well-known part of the brain that has a name to it. He was just a few years after Broca. His patient, his lesion was in a different place, in the more posterior part, in the temporal lobe, and his patient didn't have no speech. His patient had tons of speech, lots of fluent speech, but not appropriate speech. It just didn't seem to mean anything, and he had very poor comprehension. Whereas Tan, Le Borgnier, seemed to understand fairly well. So this patient is kind of a flip side patient. He's totally different. Lichtheim, who was I believe, German neurologist a number of years later, came up with syndromic names for different aphasias that we're going to learn later on from a more modern source than Lichtheim, but it does go back to that. It really does go back into the 19th century. Okay. So, but again, all the information that we have in the 19th century is inferential. It's not direct. We're not watching it happen. We didn't see it happen at the same moment. We're kind of putting together history and saying, well, if that happened, and this happened, and that is the state, then probably this caused that. But it doesn't get better than that. And so the question then is, so how do we know what we know about the brain and what it does? And we seem to know quite a bit at this point in time. And again, I've mentioned before, and this is the last time I'm going to mention it, I think, it wasn't until 1970. In 1970, computerized axial tomography, which is what it was called at the beginning, CAT scans, that name is still used. Often the axial part of it is eliminated, and so we say CT. And it doesn't need to be the brain, by the way. CTs are done of any part of the body. A number of you may have had CT scans for back problems or knees or who knows what. I'm hoping you didn't, and I'm hoping you're all well. But it does happen. It's not, it's a thank goodness there's such a good diagnostic instrument to tell us what's happening. Okay, what you're looking at is a slice of the brain, which is normal, by the way. This one is normal. Okay, this is the anterior part. This is the posterior part. What we see here are ventricles. Ventricles are open spaces within the brain that are filled with cerebrospinal fluid. Okay. CT works in kind of a funny way. CT, what you're seeing is not a picture. It's not a real photograph in a sense. It's really something that's printed by a printer, only in black and white. And what you see are anything from black to white and shades of gray. And the density of the printing, so the black would be the most dense, the white the least dense, and then the gray in between, but even there you see shades, okay, have to do with the density of the tissue. Okay, so the CT scanner, which is based on X-ray, picks up the information that it develops is how dense is the tissue that it's exposed to. And the more dense it is, the darker it will print it, and the less dense, the more dense it is, the whiter it will print. I said that backwards, and I'm sorry. The more dense it is, it will be white. The less dense, it'll be black, and then the shades of gray. What is this? That's bone. And there isn't anything that's more dense than bone, at least in the skull. Okay. What is this? I said it's liquid, and that's the least dense. And this is brain tissue. It's nerve tissue. And that's in between. And even there you see shading, but in between you see areas. Okay, sulci and gyri. Okay, where we know that we have kind of wrinkles between parts of the brain. So that's what a normal CT of the brain might look like at a particular slice level. Here you see clearly there's a problem, isn't it? We have no doubt about that. I'm not a diagnostician, but we know that there's a problem in this scan. This one is different from here. Probably the same patient, but it's done at a different level. Because these are slices, literally slices. That's the axial part of the word. It's on an axis. It's at a different level of taking a picture. And again, okay, what we see here, and here we have some diagnoses. And again, I'm not doing this so that we learn to read CAT scans. I don't read CAT scans either, but we should understand it when someone tells us about it. Okay, what we see here is an infarction. Remember, that's an ischemic stroke in the left temporal area. Remember, this is the front, so there's the frontal lobes. Here are the temporal lobes, parietal lobes, and then occipital. What we see is a stroke, and how do we know? Well, we wouldn't know it's a stroke, but we know there's a difference here, right? We see that all this normal tissue is kind of one particular shade of gray, and then this is a little bit darker. And darker means it's not quite as dense. And why is that? Because this brain tissue is dying. Okay, the radiologist or the neurologist who's reading this is telling us that it's an infarction. Okay. Let me go back to CT. CT was introduced in 1970. It was available on a very limited basis. Cities, major cities like New York, Boston, London, or whatever, had a CT scanner. Okay? It was very expensive. It was really being used for research purposes more than anything else. People didn't just have strokes and have CT scans. That was not a normal routine procedure yet. One of the places that had a CT scan was the Veterans Administration Hospital in Boston. And Boston had a unit called the Aphasia Research Center. They had funding to study aphasia. It was a multi-system unit in that it was headed by neurologists and psychologists and speech pathologists, all kinds of different people who were interested in aphasia, and they had a CT scanner. And they started to say, whoa, we have this CT scanner. Okay, if a person has a stroke, and if a person has aphasia, let's run them right into the CT scanner and let's see what's happened in the brain. Now, they were normal on Monday. They were not normal on Tuesday. Well, let's check the CT scan on Wednesday. And so we're not worried about history. We're not worried about things that happened, a long time ago. We have a normal history until day 1. Let's look at day 2 and see what's happening. And what they found, and by the way, I should say that the research that was reported was headed by the speech pathologist in the group. Her name was Dr. Margaret Nazer. Not the neurologist and not the psychologist, but the speech pathologist who had this great notion of let's do this and let's see if it links up to different types of aphasia. Is the site of lesion going to tell us anything in predicting the kind of aphasia, or the opposite? Is the kind of aphasia going to predict the site of lesion? Because we can behaviorally test the patient and say, oh, he seems to have Broca's aphasia. Remember, those terms had come up 100 years already, 100 years before. So, will we find a lesion in Broca's area if a person has Broca's aphasia? If he has Wernicke's aphasia, will it be in Wernicke's area? If he has anomic aphasia, will it be where will it be? If he has transcortical sensory aphasia, I know these are new terms so far. We haven't learned them yet. But if they have any of these types, can we predict or will we find a pattern? And in fact, they found, and again, I'm not going to belabor this, I will belabor this later on in a few days, but just to summarize what they found that if you knew the kind of aphasia that the person had, if we start that way, we have a fairly good prediction level of where the lesion is. That's pretty cool. That's pretty cool. So then the aphasia testing that we do is almost, it's not quite, but almost as good as doing a CT scan. It doesn't accomplish exactly the same things, but if all you're interested in knowing is where is the lesion, then you could do fairly well by just doing behavioral testing. What if you did the opposite? What if you didn't do any behavioral testing? What if you just line up all these people who are presumably aphasic, but we haven't tested them. We don't really know what kind of aphasia they have. And we just do CT scans. Can we then just do that and say, okay, so they have a lesion here, they must have that kind of aphasia. Well, that seems to be logical, but that didn't work as well. That did not work as well. Later on, again, we're going to talk about why that probably is true. But we do know it's true, that's for sure. We're not 1,000% sure why, but we do know for sure that it is true. And that's CT. And CT scan is still around, and it's very available. It's not expensive, compared to other diagnostic tools. It doesn't need major hospitals. I mean, many radiologists just have it in their offices. And again, I'm sure if you haven't had one, and again, I hope you've never had a reason to have one. You probably know other people who have had. The only negative to doing CT scans basically is that it's high exposure to radiation. It does use radiation, and it uses a lot of it. And so people don't do it willy-nilly. They do it when there's a good reason, and you don't do it often on the same person. Okay. 10 years later or so, a new technique was developed. And again, I'm sure you've heard of this, and that's called MRI, magnetic resonance imaging. Magnetic resonance imaging. What you're seeing here, again, it's the same type of picture that we saw before when we looked at the CT, the first one. But this is an MRI. We could conjecture it's the same brain. I'm sure it's not exactly the same person, but it's another normal brain, so it wouldn't be all that different. And we're seeing the same landmarks. Here's the frontal lobes, okay, temporal, parietal, occipital. Ventricles are here and here. MRIs are can be in black and white, but they can also be in color, which kind of makes them pretty. MRIs can be far more specific. I'm not 1,000% sure at all why a neurologist would request a CT versus an MRI. There are certain circumstances that I know MRIs are always looked at because CT doesn't give that information. Usually, almost always when it's soft tissue stuff, or even looking at blood levels and things like that. But again, it's beyond me, and it's beyond our need in this course. But understand that MRI is also available. Usually, if it's stroke, radiologists and neurologists are still calling for CTs, and that's sufficient. I'm not aware of anything that we, as a field, have learned from MRI that we didn't already know or don't know from CT. I don't think that MRI has enhanced our understanding of aphasia in any particular way, with one very serious exception. Okay. Actually, let me just show you a couple of other MRIs. Okay, again, so this is perhaps that same patient we saw before, but it's certainly a similar patient. Left temporal infarction. So this looks different, but again, it's fairly obvious that there's something going on there that's different. And here's a person with right infarction in a comparable area. And if we want, We could even see what the differences might be if we looked at the same person, and that's what's going on here. We compare CTs versus MRIs. So they look different, but clinically we're not getting very different information. Okay, I started to say before, what has MRI contributed? Well, an offshoot of MRI is something called fMRI. It's spelled usually lowercase f and then capital M, capital R, capital I. It stands for functional MRI. Because MRI is not based on X-ray technology at all, it's actually based on the magnetic qualities of the movement of neutrons and protons within an atom. And it's explained in your book. Please read it. I never quite remember it, but it's all at a very nuclear level and a subatomic level of magnetic characteristics. You can be exposed to it for hours, and there's no downside to that. And what fMRI is a continuous exposure to an MRI, watching what happens to the brain while certain behaviors are ongoing. And so you could actually just put a person under an MRI, and you can check to see, not damage, because damage is not what's happening. You can see what parts of the brain are activated during different cognitive behaviors. So you can, for example, take a person, a normal person, put them in an MRI scanner, put headphones on him and play music, and see what lights up, what part of the brain is starting to get activated. Have him do a math problem. What part of the brain lights up? Have him read a paragraph. What part of the brain lights up? Have him watch a movie or a TV show. What part of the brain lights up? And you can do this for 10 minutes, 15 minutes, 20 minutes. There's really no particular time limit. And that's something that CT could never do, because you can't expose them more than a picture, because it's dense X-ray. MRI, again, has no downside to it. And so we've learned a lot from the fMRI. What we've learned mostly, and again, I'm just giving you a very quick snapshot of this, is that MRI has told us, fMRI, that for complex cognitive behaviors, things like listening to speech, okay, or speaking, it's not one part of the brain that lights up. There may be one part of the brain that lights up more, but apparently it takes a lot of different parts of the brain for an activity that is complex to occur. Okay, that's something we're going to come back and revisit later on when we talk about different theories of aphasia. Okay, we're going to stop this tape and come back.